Welcome, everyone, to the intro session for Anatomy, Physiology, and Pathology. One of the things I've been involved over the past many years is studying pedagogical principles. What really constitutes learning? I've been teaching at a naturopathic school. I have 250 hours to teach the core principles of homeopathy with some elective time added onto that. And I realize I have to be incredibly efficient in my teaching to convey what I think is important in that time. So understanding education has been very important. But I think beyond pedagogy, the study of adult learning is very important. And I've been immersing myself in that over the past 10 years. What constitutes effective adult learning? By the way, the term that's out there for this is andragogy, which is very unfortunate. It means teaching the man. So I'd like to coin the term analekagogical principles, teaching the adult here. Okay, what constitutes effective adult learning? It's rather different than what constitutes effective learning for children, and I think it's a very important principle. We're delivering this over a state-of-the-art e-learning platform that integrates real-time activities, asynchronous or self-paced activities, delivered materials that are downloadable, links, video that's streamed, online assessment and online self-assessment, online lesson modules that are self-paced, and instructor participant and participant interaction through the website. Each module involves 10 live or recorded webinar sessions, total of 24 hours. Downloadable resources, cases, assignments, example materials, links to web-based resources, discussion through texted questions in these live sessions, as many of you are doing now, as well as an online discussion forum where we can participate in discussion on your own time. We'll have an interactive online lexicon for terminology that you can contribute new terms to, and we can involve in discussion on terminology. Clearly stated learning and outcome goals for each session, electronic flashcard reviews, and self-paced lessons on various topics on the course page, self-assessment quizzes for each session that are based on the learning outcome goals. They're not just were you there, they're did you learn what I intended you to learn, what I'd hope you'd learn from this session. And we also use these to document your participation and completion of each module. And then learning exercises. There'll be assignments that are self-assessed, and I'll provide generic feedback following your submission for documentation. And all assignments are meant as learning exercises. They're part of the learning experience here. Texts that we'll use, these two I'm sure of. The others, I'm still determining what would be the best. These are very sophisticated texts. The anatomy coloring book came out in I believe it was in my second year of medical school. I remember discovering it and wish I'd had it during my cadaver dissection course. Wonderful resource, very detailed, very professionally developed book. And for those of you, and I find in doing learning style assessments on homeopaths that most of us are kinesthetic visual learners. This provides a very kinesthetic visual learning environment for learning complex topics. So we'll be working through this. A current copy is important because I'll be keying to page numbers and particular illustrations. So if you have an older version, that might work, but it's best to have a current copy. Some people have asked, I've got a previously colored one, is that okay? And the answer is kind of, that'd be all right. But if you're the kind of person who really benefits from kinesthetic visual learning exercises, might be nice to spill the, I don't know, $17 I think it is for a fresh copy and color along as we go. Physiology coloring book, similarly for physiologic concepts. I'm looking at pathology texts right now, and these are two really excellent ones. I haven't determined which we'll use yet, and I'm going through my pile of recent acquisitions right now, trying to decide the best, rather than have you buy Robbins. Robbins' Pathology was the text they told us in medical school, don't ever read in bed at night, because medical students have been discovered in the morning having suffocated under their copy. So we'll go to more accessible and less smotherable resources. I'll provide links for these books on the website. I'd recommend the Barnes & Noble online bookstore, or if you or perhaps the Powell's bookstore online. I'll provide links to these so you can do these. So what about anatomy, pathology, physiology? An interesting story in the history of our profession. In 1867, the Homeopathic Medical College of Pennsylvania, which was founded by Constantine Hering, Adolf Lippe, a few other colleagues, had just pulled itself out of a bit of a financial crisis and were finally looking financially flush. At which time Adolf Lippe pulled a very interesting move. Not for cost-cutting measures, because that was no longer a necessity, but he decided that the chair of pathology at the school was no longer necessary. This was Charles Rao. He decided the chair of pathology was no longer necessary as the study of pathology he considered contrary to pure homeopathy. He stated the homeopathic physician doesn't need pathology, but only the powers to prescribe according to the methods of Hahnemann from the totality of symptoms, stating the disease consists only of the totality of its symptoms. Note the old schools, meaning conventional allopathic medicine's futile attempts to discover the essential nature of disease, prima causa. Okay. Now, this decision led to the resignations of both Hering and Rao from the medical school they'd helped found, and their founding of the Hahnemann Medical College of Philadelphia, which operated now parallel to Lippe's school. And in the annual meeting 1 year after the founding of the Hahnemann School, looking back on this decision to split off and start a second school in which pathology would be included, stated, a large number of homeopathic physicians are in the habit of recommending that their students attend one or all of their courses of lectures at the allopathic schools, okay? Alleging that the general medical science as well as surgery can only be successfully acquired in that way. In other words, the necessity for them to include these courses of study in the homeopathic college, in the Hahnemann College of Medicine, was that those students who were attending the other school, the one that did not include these courses of instruction, a lot of the professors were saying, take your pathology courses at the conventional medical schools, okay, because that's how you're going to get it. Now, this is a situation we're very often in today, that in the course of our medical training, of our homeopathic training, a lot of students are directed to get their anatomy, physiology, pathology courses at a community college, in a course that's designed to treat, to train med techs, to train massage therapists, etc. And those courses are oriented from a conventional medical perspective. Okay, and I want to suggest that this is really short-serving ourselves. Okay, short-serving, is that the right word? We look at some of the teachers in our tradition, like Lippe, who says pathology teaches us only such symptoms as must by necessity always be present in a given form of disease, that are characteristic of the disease only, but do not include, and of necessity cannot include, the peculiar extraordinary symptoms of any individual, really seeming to demote the value of any pathological assessment. And Kent goes even further, saying all pathological changes must be regarded as the results of disease, since all disease is dynamic, and therefore pathology, in at least in this lecture of Kent's, can't inform our practice of homeopathy. I want to suggest that these statements were possible for two different reasons from these two different people. Number one, Adolf Lippe was thoroughly trained as a physician. I find myself often finding that my pathological knowledge is getting in the way of my activity as a homeopath, and so I can understand how Lippe may have felt this way. But Lippe's little gray cells were full of knowledge of pathology, and sometimes when we're full of knowledge, it's easy to disregard the importance of things that come very naturally to us, right? A master chef might suggest that learning how to saute is trivial, okay? But early in our training, I think we would realize that that's an essential skill to becoming a chef. Am I making sense? So I think Lippe was able to dismiss the importance of pathology because it was so innate and second nature to his thinking. I think Kent was able to dismiss this on a purely theological perspective, okay, that he theologized medicine, which maybe okay and not okay, but it's not the practice that Hahnemann handed down to us. So I want to ask a big question. Is a knowledge of the body in health and disease solely the province of conventional medicine? Or does this belong to us as well? Right? Hahnemann tells us in that lengthy footnote to Aphorism 1, he seems to suggest to us that a knowledge of what's going on in the body isn't important and can get in the way, right? He has that lovely statement that I wish, I could do when I stand in front of a group of medical doctors, talking about how, we have too many chairs of theoretical medicine, okay? But was Hahnemann throwing out a knowledge of the body in health and disease, or was he saying, don't let your theoreticizing, don't let your theoretical speculations on health and disease guide your therapeutics, okay? I think Hahnemann would have told us that understanding anatomy, understanding physiology, understanding what we can of pathology on the basis of observation, as opposed to on the basis of speculation, is valuable to us in practice. Here's a little ditty from R.T. Cooper, Clinical Lectures upon Inflammation and Other Diseases of the Ear. And he says, regarding Meniere's disease, this is a conventional diagnosis that involves vertigo of unexplained origin that lasts a period of time, okay? He says, just pause for a moment to consider how utterly fortuitous is the teaching of those who would have us depend upon symptoms alone as our guide to treatment, and who, despising pathology, would look upon the tinnitus and vertigo of cerumen impaction in the ear canal as an indication for drug administration equal in importance with a similar symptom arising from exudation within the vestibules of the inner ear. Okay. Two very different pathologies, resulting in very similar or perhaps even indistinguishable external symptoms. And he goes on to say, such individuals as these are a perfect nuisance in homeopathy. Their absurd declarations bring disgrace upon a glorious revelation in scientific medicine. Okay? So understanding the origin of symptoms in a particular pathology may be important. Pressing chest pain, okay, from an inflammation of the cartilages of the rib cage, and pressing chest pain from a coronary artery occlusion in the heart are very, very different phenomena and require very different approaches therapeutically, whether it's homeopathy or otherwise, okay? Even though symptomatically they may look very, very similar to us. And for this reason, I think understanding the pathological basis of symptom expression is important for us. When we hear of pressing chest pain substernally, we need to look a little further in order to determine its source and allow this to help us inform our choice of homeopathic prescription. So I want to ask, can we establish an appreciation of anatomy, physiology, and pathology, etc., from the perspective of homeopathic medicine, rather than having to borrow this along with the attendant conventional medical philosophy? And can we do this without outsourcing our training in these disciplines? Okay. In other words, can we create an appreciation of anatomy, physiology, and pathology that come from our perspective rather than are borrowed from another's perspective? So I want to just walk through a few little very brief examples of how we might do this. And these are examples of things that I'm going to elaborate much further on in the course. So belladonna, Atropa belladonna, very well-known homeopathic remedy. Okay. Now, physiologic understanding of this plant, biochemical analysis of it, reveals that this, along with stramonium, hyoscyamus, contain a particular kind of alkaloid called tropane alkaloids. Okay? And in belladonna, we see a mix of primarily of D-hyoscyamine and L-hyoscyamine. Collectively, that mix is called atropine. Okay? These are just mirror images of the same molecule we call atropine. Now, atropine, we know from physiologic studies, okay, does a very interesting thing. It inhibits the parasympathetic nervous system, okay, the vagus nerve. One of the early studies on this looked at, I believe, a frog's heart in a petri dish, and the individual stimulated the parasympathetic nerve, and the heart slowed down. Okay, and then he took the liquid from that solution, and he bathed another heart in it, another frog's heart in it, and that heart slowed down as well. So he said there's something that was emitted by that nerve into the solution, which then acts on that second heart as well. Okay, he called it Vegasstoff. It's German, all right, Vegasstoff. So the parasympathetic nervous system is blocked in its activity by these tropane alkaloids. Okay, it blocks the transmission from the parasympathetic nerves to the end organ. Okay, and we end up with a situation as if the vagus nerve were removed or inhibited in its action. Now, the purpose we'll find of the parasympathetic nervous system and the vagus nerve is sometimes summarized as rest and digest. So I want you to imagine a scenario for a moment that you're driving along the road and minding your own business, and suddenly a car pulls up rapidly behind you and turns on its flashing blue lights, or whichever color they happen to be where you live, and it's the police, and your heart rate goes through the roof. Okay, all right. The sympathetic nervous system kicks in. That's the fight or flight one. Okay, so your heartbeat speeds up, and you get this feeling of fear and spaciness in your head, and your pupils constrict, and all this stuff, and your gut shuts down, and everything turns in to prepare you for fight and flight. All right, and then that car suddenly pulls out into the left lane and passes you at high speed and whips off down the road. This is when your parasympathetic nervous system kicks in. You don't merely relax by the cessation of that sympathetic activity. This is a very active process. These nerves jump in, okay? They start secreting their stuff, and your heart rate slows down, and you feel more calm, and you give the ah. Okay, this is the nervous system. Okay, it's the one that is kicked in when you're doing yoga, when you're doing relaxing asanas, when you're doing meditation. Okay, it kicks in. Okay, and slows you back into that rest and digest state. But you see, belladonna prevents this. Now, understanding this physiology, we can much more readily understand the actions of belladonna on our system. Okay. This is part of a portion of my map of belladonna, okay, and the major polarity that I distinguish is between quiet and calm and wild, okay? Wild being that fight or flight feeling with the desire to hide, and the violence that we both know to be very true of this remedy, right? Fight or flight, okay? Fight or flee. Now, one of the things that's different in a belladonna state, someone who needs belladonna, okay, or someone who's doing approving of belladonna, is the moving from quiet to wild, quiet and calm to wild, is unrestrained. Okay, because of the lack of a parasympathetic nervous system, this movement from the normal quiet calm state to the wild fight or flight state is unrestrained, so it happens very suddenly. Okay, much more suddenly than for the average person. All right. Okay. And once we're there, and the police car speeds off and leaves us, and now the parasympathetic nervous system is supposed to kick in and bring us back to quiet and calm. It doesn't for belladonna. Okay, it's very slow to return to the quiet and calm state and the rest and digest state, because that activity, that active relaxation, is severely inhibited in the belladonna state. Okay. All right. So now we understand the suddenness of this remedy. We understand the fight or flight, the wildness, the desire to hide, the violence. We understand why in a chronic belladonna state, we usually encounter the individual in a very quiet, calm kind of setting, okay, trying to maintain that, because it's so difficult to return there after they're perturbed from it. The issue with belladonna is not that it's wild. The issue is that it doesn't return from wild to calm easily, and it goes from quiet to calm to wild in an unrestrained, unbuffered kind of way. Okay? So there are many other stories of remedies that we can learn by understanding this physiology and tying it into the pathologies that we see in practice. Okay? Now, is a case that I recently used in the Small Remedies course that I just want to talk about. It was top of my mind, so I'll use it for an example. Here's a kid who's presenting with a miliary scarlatiniform rash, okay, like fine sandpaper in this distribution, the perioral clearing, okay, involving the face, the upper chest, front of the throat, the armpits. They have swollen, inflamed tonsils with a little bit of pus on them, just a little bit. There's swelling and tenderness of the anterior cervical lymph nodes in here. There's a high fever, and when we run through the little scoring process of symptomatology, the clinical strep score, this is not the screen on the swab from the throat, but just based on our symptomatology, which doctors in my day were taught to do, the strep score is 5 to 5. 5 over 5, which means we should not bother with a strep test, because even if it's negative, we're not going to believe the negativity of it. This is strep, okay? It's an obvious strep throat, all right? And it's scarlet fever, okay? And the miliary rash makes that strep diagnosis absolutely ironclad. Okay? So knowing this, we can come up with a diagnosis. And I would suggest that there are times when a diagnosis is reasonable. Okay, Hahnemann doesn't rule this out. In fact, is it aphorism? I can't ever remember the numbers. Is it 72 or 73? Something in there where Hahnemann talks about the nature of diseases. He says there are some acute diseases that are so invariable, so consistent in their presentation that they earn a name. Okay, and the miliary scarlatina of Sydenham is one of these, okay? So we can call this scarlatina or scarlet fever even if we're a homeopath. Does this help us find the remedy? Well, it kind of does. Here's a clinical rubric assembled by the experience of clinicians, okay? 60 remedies and 6 more if we go to the complete synthesis of remedies that have been described as useful in the treatment of scarlatina. I would do a little surgery to this. The most prominent of these is belladonna, okay? And actually, it's our job, in any case of scarlatina, to find a reason not to give belladonna, okay? Right? It's kind of like in whooping cough. Find a reason not to give Drosera, you know? Are there symptomatologies that pull us away from this more generic kind of interpretation of the case, okay? So yes, it can help us to say this is scarlatina. It doesn't tell us which remedy to use, but it gives us a field of likely possibilities. Now what we have to do, of course, is say what are the symptoms of this individual that might pull us away from a more generic definition of this case. Okay? So here we have a case, in this case, it's a dusky purplish discoloration rather than the typical bright red. Okay? Both of the rash and of the oropharynx. The fever is intense with delirium, but the delirium is soporific and muttering, is sleepy and not too responsive. It's not an excited or fearful delirium. It's more of a sleepy, muttering kind of delirium. The pace is very interesting in that the chill accompanies heat, okay, rather than heat and then chill and then, or rather than chill and then heat and then perspiration, a typical succession of stages, okay. Of course, belladonna, we'd see heat alternating with chill or continuous heat, okay. Here we see the chill accompanying the heat phase of fever. Interesting pace. Chill is not relieved by external heat, kind of an upside down modality, okay, useful to us. So as many covers are on the bed or a hot bath or whatever, the chill's not relieved. And there's a constant, and the sore throat is worse by swallowing, which doesn't get anybody excited, because of course it would be. If it's not, that would be interesting. But that highlights the fact that the patient is constantly trying to swallow, has this constant disposition to swallow. So we now have some, in addition to the common symptoms of, quote, the disease as named, we have unique and distinctive symptoms of the patient. And as much as we've seen some authors tell us this is the only thing we should be interested in, I would disagree. And I think we'll find ample evidence in our literature to suggest I'm on good grounds here. Our remedy has to cover this. It has to cover the common features of the disease. It also has to cover the individualizing symptoms of this patient. And when we do this, we come up with Helleborus or Helleborus niger as a remedy. Now, this is interesting for a couple of reasons. The most obvious reason is now we have a simillimum to treat this individual with. I won't go through the analysis here. I'll let you do that on your own. It's a fun one. We can find this mentioned in the clinically established rubric. This is an approving rubric, of course, right? It's established by clinical experience. And this helps us feel good, okay? But here's why this is particularly interesting, is that we find in Helleborus inflammation of the kidneys from scarlet fever, albumin in the urine from scarlet fever. This is because there's been damage to the kidneys, and we'll study the pathology of this, the actual pathophysiologic process here of how this happens. There's spilling albumin or protein in the urine, okay? And there's a suppression of urine because it's retained and becoming edematous with dropsy, okay? Particularly edema and swelling around the eyelids before you start to see it in other parts of the body, okay? So renal failure, glomerular nephritis after scarlet fever. We'll find that following scarlet fever or other strep infections, we often can see, well, not often, rarely, but occasionally, and often enough to be concerned about, we can see acute proliferative glomerular nephritis, or sometimes called poststreptococcal glomerular nephritis. Okay, this is sometimes a self-limited condition. It goes away on its own after a period of time, but sometimes can lead to lasting and permanent damage to the kidneys. And now, this knowledge that we've gained from our homeopathic perspective of looking at the individualizing symptoms of the patient, indicating the simillimum, telling us this patient is at risk for this, helps us prognosticate and understand this is a patient at risk for this. It's not guaranteed they'll develop this, but they're at particular risk. It tells us it's essential that we treat this, and we have a tool to treat and prevent this possibility. By the way, antibiotics will result in a resolution of scarlatina in 10 days instead of a week and a half. Okay? There's good evidence that antibiotics are useful, at least were historically useful, in preventing the sequela of rheumatic fever after scarlatina, something we don't see very much anymore, probably because of changes in the nature of the bacterium. Okay? But antibiotics are not effective in preventing this poststreptococcal glomerular nephritis, something that we do have the tools of with homeopathy to help prevent. Okay, so here's an example how our homeopathic knowledge actually informs our prognostication of disease, okay, and helps us understand the potential pathologies we may be facing and the essentiality, that's a George Bushism, the essentialness. That's probably not a word either. The reason that it's essential that we treat this case carefully and aggressively. Okay. Let's look at some other cases here, and then a couple of questions. Here's a woman who presented with pain, recurring pain in this region of her neck here. Okay, persistent recurring pain. A lot of difficulties with this, interfering with her life, and so on. On quick assessment of the patient, okay, determined that this is trigger points in the levator scapula muscle here, okay, knowing and knowledge of the anatomy and a knowledge of the misbehavior of muscles. And myofascial pain is a area of particular interest of mine. I met Janet Travell on a train once many years ago and ended up apprenticing with her and working a great deal in chronic pain in that period of my life, just prior to my discovery of homeopathy. So we're going to look into this and understand the nature of myofascial pain, very essential, very big part of medical practice today. Okay, so her pain is coming from levator scapula here. Okay, you can understand the anatomy of it. And we understand that the levator scapula is primarily a postural muscle. Okay, which leads me to ask questions about posture. Okay, is there something that's creating and perpetuating this? Now, I could dig through my repertory and look for neck stiffness, neck pain on motion, etc., and give her remedies out the kazoo and actually end up doing nothing for this particular patient, because the issue here is not so much a dynamically maintained disharmony as it is a posturally maintained. In other words, there's an external perpetuating and maintaining factor for her pain here. On asking her to take off her shoes, here's her feet. Okay. And we'll find she has what's known as a Morton's foot. This is a particular form of foot anatomy. Typically, these metatarsal joints here, okay, will march off like this, okay, so that the first metatarsal is the longest, the second is slightly shorter, and so on and so on. That's the typical foot conformation. In a Morton's foot, Dudley Morton did not have a Morton's foot, but this is named after him. The first metatarsal is shorter, okay, and it produces a very interesting foot conformation here. One of these is that the transverse arch across the foot here is collapsed and flat, so you very often will see a callus underneath that second metatarsal head. Okay, if you look at the foot, at the sole of the foot, this will be flat across instead of slightly arched away from you like a bow, lifting this off the ground. Okay, when the person walks, instead of toeing off here and here, okay, off the first and fifth metatarsal heads, the second one gets in the way, and they have to develop a very subtle rocking or rolling gait that often they don't know. They don't recognize because they consider it normal because they've been doing it since they were 1 year old or 11 months, whenever they started to walk. Okay. The intervention for this patient, based on this and our knowledge of posture and of anatomy that tells us we should look for this kind of thing, okay, is this. Okay. Now, we might provide this intervention, or we might know that we send them to Ray McClanahan at Northwest Foot and Ankle in Portland, Oregon. Okay. Accept no alternatives. A wizard of a podiatrist. Okay. They get a metatarsal pad here, okay, that supports that second metatarsal, lifts it off the ground, restores this transverse arch. It's not the longitudinal arch we're interested in. It's this transverse arch that we want to maintain, okay, with that metatarsal pad. And often we add toe spacers because you see how this toe is not like a baby's toe out here. Okay, so we add some toe spacers to provide a more normal positioning of the toes and the metatarsals in gait. We also engage them in some exercises for the feet. They can't wear pointed shoes. They can't wear raised heels. Okay, they need to wear either bare feet or good footwear and help them find effective footwear. If you want references to good information on that, I can help you find that. Okay, so here our knowledge of anatomy, of physiology, of myofascial pain. Janet Travell observed that of those individuals with chronic persistent myofascial pain, 80% have a Morton's foot. Okay, rather remarkable. Knowing to look there helps us to come up with an appropriate intervention. And Hahnemann tells us, you know, he is also an effective physician who knows how to identify those things which cause disease and knows how to intervene in these. In the same lines, I had a patient who presented with vertigo, rather severe vertigo. He'd gone to a concert of some aging 60s rock band. I can't remember which one it was now. And afterwards had troubles with his ears and then developed really severe vertigo. It's a man in his early 70s, I believe. So he presented with severe vertigo, and I took his case, and I'm thinking of vertigo remedies, but licked in his ear. Now, some of you may be able to lick in ears, and some of you may need to send to a colleague who knows how to lick in ears, a nurse practitioner or a physician that you've developed a relationship with, who's permitted by law to do these exams. I find it rather ludicrous that the law prevents some of us from doing this. When we look at physicians' assessments on otoscopy, using an otoscope to look in the ear, we find that they miss appropriate findings, over 60% of the time. It's my belief that physical examination skills such as this or listening to the heart, that with about 12 weeks, I could train half of you to be more effective than 50% of the physicians out there. So I'm not telling you that you should break the law and examine your patients if you're not licensed to be able to do that, but I think it's a ludicrous thing. We can talk more about that. But anyway, an examination of the ear by you or by someone who's permitted to do that He had a cerumen impaction in his ear. Okay. Treatment, we put stool softener in his ear. Okay, Colace. I know it's not stool in there, but this works better than anything. Okay. You just pop a little safety pin into the end of the gel cap and squeeze it, and the oily contents of this gel cap come out into the ear canal. You let it sit there with the ear up for about 20 minutes, and then you flush it with warm water. This is just a fancy ear syringe. You can use one of those bulb syringes they use for babies, you know. And boom, the cerumen is where it belongs instead of here, impacted in the ear. Okay. And now we tell him, next time you go to a rock concert with an aging 1960s rock band, number one, maybe wear ear protection, but probably not plugs that go in the ear. And after you get home and your ears feel weird, okay, don't start to clean them with a Q-tip, okay, because then you impact the cerumen. We're also a sustainer of health if we know the things that disturb health and engender and maintain disease and are aware of how to remove them from healthy people. And, you know, all of the cocculus and conium and whatever other vertigo remedies we can summon up in this case wouldn't have done anything because the intervention needed to be cerumen removal. Now, we're not necessarily done with this case, are we? I mean, we have to ask the question of, you know, why are you someone who gets cerumen in your ears? Is that an issue that maybe is a dynamic disharmony that we can address homeopathically? We also have to ask the question of why are you in your 70s going to rock concerts with aging 1960s rock bands? Is that pathology or not? Perhaps, perhaps not. I realize I'm going to run way over my hour tonight, so I hope you guys are ready. Most of you knew to anticipate that. Okay. A woman came to me once, actually referred by her family physician to see me with postherpetic neuralgia. He didn't quite know what to do. She'd presented very early in the course of shingles, right? Just as the blisters were starting to come out on her face. And he was concerned because of the distribution on her cheek and temple that they might involve the eyes, so he wanted to jump right on this. Okay, so he started her on acyclovir, an antiviral. Okay. Now, she came to see me. The rash was gone. The blisters were resolved. There only had been a few, and he had managed to treat them very early. Okay, but she had severe neuralgic pain. Okay. So we can look up neuralgic pain after herpes zoster and extending downward because her pain started in the temples and cheek and went down her face and into her neck and out into her shoulder, even though she'd had no blisters in that area. These quickly give me the remedy, and there were a few more remedy symptoms to the case, okay, but they gave me the remedy Kelmia latifolia, the eastern mountain laurel. Now the problem was this, that in addition, you know, because I'm a homeopath, I'm taking her case pretty thoroughly. In addition to having this neuralgic pain, this woman had a history of well-compensated congestive heart failure. Okay, she was on a couple of medicines, low doses for these. It was well managed for quite a few years, but now it was getting worse. She was having swollen ankles in the evening before bed. She was having a little trouble breathing at night and had to sit up on a couple of pillows. Very characteristic of congestive heart failure. Okay, fluid out in the lungs here at night, settling to the lowest point when she's lying down, during the day going to her ankles. Okay. As a homeopath, we see with Kelmia, we see illnesses from suppressed skin eruption. Okay, and the acyclovir was doing this. And we see problems with the heart valves with Kelmia, okay? Difficulties with the heart valves. This is a big remedy for heart valvular problems after rheumatic fever, okay? So I was able in this case to, number one, call her physician and say, you know, doc, you need to stop the acyclovir, okay? And he said, I don't understand why. And I said, well, I do understand why. It's very important in this case. And we're going to have to let her have some blisters, okay? So he did. He was a good guy. He understood the limits of his knowledge, and I understood the limits of mine, hopefully. He stopped the acyclovir. Okay. Just a little, we're going to learn about rheumatic heart disease, of course. Okay. He stopped the acyclovir. She got a few blisters back on her temples and cheek. The neuralgic pain resolved. I started her on the Calmia, and the heart failure resolved. And then I was able to give him a call back and say, Doc, this long-standing congestive heart failure of hers, I don't hear any murmurs from the valves. And I notice in your notes that he'd sent to me that you haven't either, and you got good ears, but I think she's got a valve problem. What do you think about echoing her heart? He said, nothing to lose. So they did an echocardiogram of her heart. Sure enough, she's got a severely stenotic mitral valve, so stenotic, so narrowed, that you couldn't even hear the murmur from it anymore. Okay? Valve surgery for her, they were able to get her off of her medications. Weigh the pros and cons of valve surgery today versus the side effects of the medication she was on. Much better ahead with the new valve, okay, in this case. Okay. So here, a knowledge of our homeopathic pathology helps us understand that we need to stop the suppression of the skin eruption. We can link it to the congestive heart failure, and we can predict what's causing that congestive heart failure for her with reasonable certainty, so that we know that the echo was reasonable to do, and that there's a valve that probably needs some attention. We're going to study skeletal anatomy and muscular anatomy. Of course, this is really important to us, but in addition to studying, for example, the structure of the shoulder and here the rotator cuff and its function of the body, we're going to look at what goes wrong with it. This is why I'm going to integrate pathology with the anatomical studies. Okay. So one thing that we commonly can see is rotator cuff tendinitis, looking at sources of shoulder pain. Okay. And this is from microscopic tears in these tendons where they impinge between the head of the humerus and the sacromion above. You see, the pathology of a rotator cuff tendinitis is that tendon gets pinched in between this bone and develops microscopic tears from this contusion in between those two hard structures. So this is a laceration from contusion with either microscopic tears or sometimes gross tears. What do we use as a remedy? Calendula almost invariably is the indicated remedy in these rotator cuff tendinitises. Okay? The rubric: wounds, lacerated and torn. Okay? Lacerations from contusion tend to call for calendula. There's a wonderful old case from Yingling, right? I don't know if you recall the one of a man awoken from his slumber on a Sunday morning by a screeching cat, and Yingling, of course, is a Methodist minister, so the fact that he's sleeping at home rather than attending church kind of riles him, right? So the man picks up a stone and throws it at the cat, and has this severe shoulder pain. Okay, rotator cuff tear, and Yingling treats him with calendula, very high potency. The other place we can get shoulder pain, another place commonly, is a bicipital tendinitis. Okay, from this long head of the biceps tendon here that comes up and attaches to the shoulder here. Now this travels through a tunnel, through a sheath, and sheathed tendons are very particularly the domain of ruta, graveolens, okay? And the pain tends to involve adhesions between the tendon and the tendon sheath that continually start to heal and get torn and start to heal and get torn, and often are very chronic. So pain originating this bicipital tendon, and they're very simple examination procedures that can distinguish between this and this. Okay, even though they feel very much the same, very often calls for ruta, more often than anything else. A subacromial bursitis, this bursa or purse, it's called, is like a balloon of tissue, okay, filled with serous fluid, and this can be inflamed as it's pinched here as well. And if the pain is from an inflamed bursa, we're looking at remedies like apis, if there's an effusion of fluid in here, or brownia, if it's dry. Okay, our symptomatology will help us determine if it's an inflamed effusive bursitis or an inflamed dry bursitis. Similarly, looking at the affinities of these remedies for particular tissues, the affinities of apis and brownia, very particularly for serous fluids, tells us these will be remedies that come in importantly in pericarditis. another inflammation of another serous membrane, here the one wrapping the heart. Okay? And we can distinguish them, the indication for remedy, based on our homeopathic indications. Bryonia, dryonia, right? This will be dry. There should be a little bit of fluid lubricating this space between these two layers of pericardium about the heart, okay, so that it can move frictionlessly. When this is particularly dry, we listen with our stethoscope and we hear a friction rub. We hear lub, dub, lub, dub, lub, dub, okay? When we need apis or colchicum, for example, these are remedies that have tremendous effusions, and so this space will be inflated with serous fluid, okay? Inflated around the heart, actually potentially enough to restrict the filling of the heart, okay? And so we'll hear diminished pulse sounds, diminished heart sounds with a stethoscope over the heart, because there's an insulating layer of fluid between us and the heart, so the heart sounds much fainter than it should. We'll also see a reduced pulse pressure in the arm, because or other limbs, because the heart can't fully fill, can't get a full volume out into the arteries. Okay. So we'll be studying different parts of the anatomy and physiology. We'll be looking at the kidney and the details. It's incredible collecting ducts of the kidney and how these operate, where things are filtered, where various drugs act in this process. We'll be studying the heart, this conduction system, the flow through the heart, understanding the relationship of the EKG tracing to the conduction of electrical impulses in the heart. But, in conventional medical circles, this is often studied within a very mechanistic reductionist philosophy, where the kidney is a series of filters, okay, and the heart is a pump, okay, thought of in a very mechanical kind of way. And we're going to break out of that mechanist reductionist philosophy and look at these as processes we can describe using some of the principles of physics, some of the principles of chemistry, okay? And yet there's much that we can't understand, the importance of these organs, that we need to have an expanded knowledge of the dynamics of life to fully appreciate. Okay? Often medicine is fascinated with simple heuristics, and I realize here I have to change my... No, I don't. Okay. Fascinated with simple heuristics, like with depression. There's this concept that goes around, and if you go to a doctor with depression, they're going to tell you, oh, you don't have enough serotonin, okay, and you need more serotonin. You need a drug that increases your serotonin level. That's a simple heuristic. The complicated heuristic looks more like this. There's a bunch of intermediates, but the bottom line is that depression is a disease of serotonin deficiency, right? This chemical imbalance model of depression. So I just want to look at a little piece of public media for a second here, okay? And pardon the sound on this. I'll try to make it decent.
You know when you feel the weight of sadness. You may feel exhausted, hopeless, and anxious. Whatever you do, you feel lonely and don't enjoy the things you once loved. Things just don't feel like they used to. These are some symptoms of depression, a serious medical condition affecting over 20 million Americans. While the cause is unknown, depression may be related to an imbalance of natural chemicals between nerve cells in the brain. Prescription Zoloft works to correct this imbalance. You just shouldn't have to feel this way anymore. Only your doctor can diagnose depression. Zoloft is not for everyone. People taking MAOIs or Pimozide shouldn't take Zoloft. Side effects may include dry mouth, insomnia, sexual side effects, diarrhea, nausea, and sleepiness. Zoloft is not habit-forming. Talk to your doctor about Zoloft, the #1 prescribed brand of its kind. Zoloft. When you know more about what's wrong, you can help make it right.
I find that fascinating. Now, that was designed for public consumption, but very similar explanations are provided to the physicians that people are going to see. Okay? Wonderful story, and Google it. When it comes to depression, serotonin isn't the whole story. This is on an NPR, National Public Radio News in the U.S. news story. If you Google NPR serotonin depression, it'll come up first, and you can listen to the whole article or read it. Alan Frazier, University of Texas Health Sciences Center. I don't know of any story that has supplanted this story of chemical imbalance and depression. Pedro Delgado, Chair of Psychiatry. It definitely continues to live, absolutely. If you go to your community doctor, you're likely to hear some version of that story. Joseph Coyle, Professor of Neuroscience at Harvard Medical School. I love this statement. Chemical imbalance is sort of last century thinking. It's much more complicated than that. It's really an outmoded way of thinking. Okay, now we're going to study some of the explanations that conventional medicine uses to describe the pathology and pathophysiology of disease and the justifications of its interventions, because we need to know this to be conversant with medical providers. But we're going to look beyond these here, okay? And this is a thing that I find, if you line up practicing physicians, they're going to give you the party line of the chemical imbalance theory of the nature of depression, which is last century thinking by a guy who really knows about this kind of stuff, okay? So we're going to study what's last century thinking and what's this century thinking. But here's the kicker, just a little piece of that video played again.
Depression may be related to an imbalance of natural chemicals between nerve cells in the brain. Prescription Zoloft works to correct this imbalance. When you know more about what's wrong, you can help make it right.
This is the supposed promise of conventional medical science, is that when we know what makes it wrong, we can make it right. A mechanistic reductionist model, okay? And we're going to try to look beyond this. We're going to learn those stories, but look beyond them as well. Kurt Kafka tells us that the whole is not greater than the sum of its parts, often misquoted, but other than the sum of its parts. The whole is different than the sum of its parts, and we have to understand the whole. We can play all we want with the parts, okay? And that's fascinating, and we're going to learn a lot of that. But we have to look beyond it to understand that we're dealing with a complex adaptive system here. The human organism, the living organism, any living organism, even an amoeba, is a complex adaptive system characterized by self-organization, distributed control, self-similarity, rich interaction, nonlinear interactions, recurrency, emergent behaviors, adaptive capacity, homeostasis, resilience in the face of perturbation. It operates under far from equilibrium conditions, and it's historical. Its past is co-responsible for its present behavior. We are not a simple machine. Conventional medical science still views the body as a simple machine and takes a mechanistic reductionist model of approach. Okay, we need to start viewing the body as a complex system. Okay, and we're going to take a look at the properties of complex adaptive systems and how this informs our ability to understand how the body works. I'm going to skip over the adaptive cycle stuff. We're going to go into, many of you I've talked about this in other courses. We're going to go into a great deal of detail about the adaptive cycle model as we look at various organ systems and their functions. And I'm excited because this is something I've been playing with for a few years now. I've kind of dabbled and dropped off little bits of this thinking in courses here or there, but we're going to go into in depth on how we can understand disease in a much more effective way using this model. Now, it's important to understand the past, okay? Very important to understand the past. We have this concept of the vital force or the dynamis that gets tossed around as kind of a uniform idea, often not described in detail. I think we have to understand what has been suggested for this. And so someone asked earlier, is there going to be some history? There has to be some history here, okay? We have to look at the histories of animism, of vitalism, of dynamism, and understand how these are similar and how these are different, okay? Hahnemann was not a vitalist, okay? Hahnemann was a dynamist. These are very, very different, and the difference between these is essential in informing our practice of homeopathy, okay? Dynamism has much more to do with the philosophies of Leibniz than of the vitalist philosophy, and we have to study the differences between these and understand how dynamism can help us understand both homeopathy and the operations of the physical body, and understand the differences between dynamism, animism, and vitalism as properties. This slide was going to have a transition, but we'll skip that. There's a common concept that as we move into the present, our knowledge, the knowledge we gain, is kind of a linear progression from ignorance to truth, okay? This is a common perception. And I think it's very, very unfortunate and very wrong, particularly when it comes to medical science, okay? That in the progression over time of our knowledge of medicine, we have not moved from merely a position of ignorance to a position of knowledge, but rather we've entered a number of cul-de-sacs. The decisions and philosophies and beliefs that we've encountered along the way have steered medical science into some particular difficult arenas, into some dead ends of thought, okay? We've left behind some important insights, some of Galen's very important insights about the nature of the soul, okay, and the nature of pneuma and the soul are very, very important to understand the body. These have been left behind as the mistaken beliefs of someone with a very primitive kind of science because he didn't know how the blood circulated. We have to look at this to understand what we've left behind and what dead ends we're stuck in today. For example, today we're stuck in a mind-body dichotomy. Conventional medicine is trying to figure out how to bring the mind back into the body, right? With such studies as psychoneuroimmunology, how does what we think affect how our body operates? It's a dead end we find ourselves into. We don't have to reconnect the mind to the body. If we go back to that point in history where we decided to disconnect them and don't disconnect them, okay, and move forward from that place instead of moving into a dead end that now we need to back out of, okay? So in the course of this, we're going to encounter people. We're going to have to study some history. Hippocrates, the Alexandrian Medical School, Galen, Al-Razi, Ibn Sina, Avicenna, the early medical schools of Europe, Salerno, Bologna, Padua, Vesalius, studies of anatomy, William Harvey, studies of the heart, René Descartes, right now he's a villain in my eyes, backed us into some corners that hard to get out of, Sydenham, Borhave, Morgani, Linnaeus, von Swieten, and the establishment of the University of Vienna, where Hahnemann received his the essential core of his medical education, Barthez and Montpellier, and the Montpellier version of vitalism, etc. And this study is going to be scattered in between because in order to understand where we are today, we need to understand how we got here, okay?